We've been reminded many times this morning that atherosclerosis is the major cause of mortality and morbidity worldwide now. The disease process has a wide spectrum from the initial intimal thickening fatty streaks to a more complex lesion where have proliferation of the muscles. And in advanced lesion, you'll have the fibrous cap, usually thin, indicating rupture or imminent rupture or vulnerability. The large lipid coil, also a sign of vulnerability. The biophysical properties of the lipid itself, if it is semi-solid or liquid type, it's lead to soft plaque, which can contribute also to a sign of vulnerability, inflammation as well. This all has been mentioned by previous speakers, and I thank them for setting the scene for my talk. We have a number of imaging modalities which we can use for assessment of the arterial wall. Each has advantages and limitations. Echocardiography, the external ultrasound is non-invasive, cheap, widely available. We have the CT scan now at the cost of radiation. You can look at the lumen as well as the arterial wall itself. Invasive MR is another non-invasive technique whereby you can look at the lumen and the arterial wall in various vascular bed. We have the invasive technique like IVUS, intravascular ultrasound, and optical coherent tomography. Those are more invasive, and therefore follow-up of patients for looking at natural history or progression of the disease can be a little bit more problematic. I'll stick today to the MRI and CT because the others will be covered by other speaker in tomorrow's session. And I would like to begin by this case presentation. This is a 74-year-old male. He presented with loss of vision in his left-sided eye. Fundoscopy showed branch retinal artery occlusion, and carotid artery duplex scan showed only mild stenosis, range of 20% on the ipsilateral left carotid artery. He is an eminent physicist, and in fact, he is one of the first people who put a prototype for MRI machine in the early 80s or late 70s. And he heard about us recruiting for studies, so he asked if he can volunteer for the study. And we looked at the arterial wall imaging here. In fact, you can see this is the internal carotid artery, and this is the external carotid artery. You see the lumen is quite respectable, but there is a large atheromatous plaque sitting in this region at the origin of the internal carotid artery. And when you produce cross-section of it, this is what you see. You see that the plaque eccentric in this region. And one of the advantages of MRI, you can play with the signal so as to give the signature of the signal to different component of it. So when you produce a T1-weighted image, it's good, give you good anatomical details of it, size, and also the shape of it. But if you do a T2-weighted images or other type of technique, it can change the contrast, the intrinsic contrast, so that different tissue or different material will give you different signal. And in this case, the necrotic material or the lipid pool will give you a low signal, while the fibrous cap will give you higher signal. And when you compare the two, you see there's definitely an erosion in this region, and it is a large necrotic area, so it's fit with a vulnerable plaque that perhaps partially ruptured. The problem is what to do with him, because all the criteria say that this patient has to have 70% stenosis or occlusion to qualify for endarterectomy. So we talked to a number of surgeons in London. Some of them refused to have him, but one of the surgeons, on the basis of strength of the imaging, that he decided to go ahead and do endarterectomy. And this is the specimens after it. You see that the fibrous cap is partially ruptured with thrombus in this region. If you compare it with this second case, this patient known to have ischemic heart disease. He has the left-sided facial numbness, and there was suspicion whether he has a TIA. And when you look at the angiogram, and in this case, magnetic resonance angiography, it's a luminogram. you hardly see anything there. It's only mild stenosis. But when you do the vessel wall imaging there, that's the T1 weighted images, you see a large eccentric plaque in this region. And you do the T2 weighted images here. Remember, the fibrous cap will appear bright in these images. And you see the fibrous cap is thick and uniform there. So that's an example of a staple plaque. Now, as mentioned many times in previous lectures, that in presence of insult to the arterial wall, to the atherosclerosis, you get expansion of the vessel, what's called positive remodeling or Glagov remodeling, due to expansion of the vessel wall. And therefore, when you rely on imaging technique which address the lumen only, you don't see what is outside, because the disease process in the arterial wall. It is only when there is inward remodeling that you start to see that reduction in the lumen, and therefore impinging on the blood flow and producing classical symptoms, for example, of angina. Previous speaker has explained this slide to you, that low shear stress is conducive to formation of atheroma, and then depend on the local mechanism and the genetic factor. This can be either state quiescence or progress to constrictive remodeling, resulting in stable angina, or stretch too much, especially lead to rupture at the shoulders of the plaque itself, and that can produce acute coronary syndrome. When you come to the MRI technique, it's been very useful for looking at the carotid plaque, and there's some study on the aortic plaque, and very limited study on the coronary arteries, because this is a problematic area, and I will allude to that during the course of the lecture. If you do an angiogram and you see a luminal stenosis in this left carotid artery, internal carotid artery, and this is the right carotid artery, you see very little. This is almost normal. But you see a large or severe stenosis in this region. If you do a wall imaging in this region, covering it by multiple cuts, you can look at the vessel area. And because the wall thickness, the slice thickness is known to us, so you can add them together to give you the burden of the atheroma in that region. So you draw the circle outside and on the inside. So this is going to be the vessel wall area or volume. This is the luminal area or volume. And this is the total vessel area. And you can do that automatically or semi-automatically with computers now. I just show you this patient who was part of the trial we're doing, that he's totally asymptomatic. If you look at the thickness of the arterial wall is very thick, and you can measure the volume in cubic millimeters from that images. And he was put in a high statin dose for at least 9 months, and you see now the change in the volume of that atheromatous lesion. Now, this is one of the very first mobile scanner, was done in house-built magnet, was put in second-hand double-decker bus. And the idea at that time, it was state-of-the-art, to look at, in the community, to look at our arterial wall. We studied 175 asymptomatic subjects from 7 companies who volunteered for the scan, assessed the risk factors in the traditional way. And when you look at the baseline and 2 years follow-up study, you see that there is no change in the vessel, significant change in the vessel volume, or significant change in the lumen volume, but there is significant change in the wall volume. And that tells you that there is positive remodeling in arteries like this. This one's done in the coronary arteries. Now, this is the MR angiogram of the right coronary artery, and this is the MR arterial wall imaging of the right coronary arteries. And in this study, they looked at healthy volunteers and age-matched patient with a minor, non-obstructive coronary artery disease. They have very minor disease, so they look at the wall thickness there. And if you compare the average wall thickness between the healthy volunteers and the patients with non-significant coronary artery disease, the patient has higher coronary arterial wall thickness, while there is no significant difference between the two groups, the healthy volunteers and the patient, when you measure the lumen itself. Again, that tells you that there is positive remodeling in the coronary artery. Assessment of arterial remodeling with statin here. They looked at in this study at the aorta and the carotid arteries, and they look at the vessel wall area. And you see with the high dose statin, they get reduction in the vessel wall area, while the lumen, it doesn't change significantly. And the same is applied to the carotid artery. And again, that gives you that you can get regression of the atherosclerotic process with manipulation, pharmacological manipulation. This is the same patients I showed you earlier, but with frequent follow-up. And that's the beauty of MR, that you don't worry about X-ray radiation or there's no safety issue. You can follow up the natural history of the atheromatous lesion like this. So that's before treatment, and that's following treatment. You see definitely regression in that arterial wall thickness there. For those who's interested to do this type of study is demanding, because resolution is very important there, and we're talking about at least less than 400 microns or type of resolution to get meaningful information. You can use intrinsic or extrinsic contrast to try to differentiate between the different lesions. And when you come to coronary artery, because it is situated in an area of physiological motion, you have to think of how to control motion, whether it's respiratory motion or cardiac motion. So to get high resolution, you need the coil, which collect the signal of the MR signal from the concerned vessels very close to it. And therefore, you get plenty of signal, and then you can trade the signal for resolution. Here is an example. This is to support the head, and then you flip back those small coils on the carotid artery to produce images like this. And that's why most of those studies was done on the carotid artery, because it's technically more suitable than the coronary arteries. Once you get the anatomical images and the right type of resolution, you can manipulate the signal, as I said, in different ways to give you different information. So use like multi-spectral analysis of various images to come to a conclusion about the composition and the structure of the atheromatous plaque. And here, for example, calcium will give you low signal in all type of the sequence you're going to use. The lipid content will be lower on the T2 weighted images, fibrous cap high on the T2 weighted images, and so on. So you can get a lot of information from technique like this. There's a lot of validation on vitro experiments in the early days. And this is an example in patient with intra-plaque hemorrhage. And the intraplaque hemorrhage, usually if you capture it within the first 2 weeks, it produces methemoglobin. And methemoglobin has a unusual character in that it acts like a contrast itself, because it has a short relaxation time of protons compared with the normal tissue. So you get a very high signal within the plaque itself. This is an example of, again, in the carotid artery. You see the lipid core here, the fibrous cap, and the lumen here. Now, the problem, that's why it is not so easy to do with the coronary arteries, and a lot of studies has been in the carotid artery, is that the physiological motion. If you look at the coronary artery, is like 5 millimeters in diameters or less. They move with cardiac contraction and relaxation. They move with respiration. So you have to address the respiratory motion and the cardiac motions. The cardiac motion can be addressed using ECG gating, and the respiratory motion can be addressed using either breath holding or, more suitably, a type of respiratory compensation. So a technique which you take the position of the diaphragm and every time the diaphragm to reach to a specified level, a specified position, the data will be collected. If it is outside that point, it will be rejected. And therefore, the patient can breathe normally while acquiring the data to produce images. The other problem is that not unlike the carotid arteries, where you can stick the surface coil, which is the receiver, like antenna of television or radio, to receive the signal, the coronary artery is deep in the chest, so it is not so close to it. And that's, again, why it is more challenging to look at the coronary arteries. This is a coronary angiogram looking at the lumen in this case, and you can see that properly done with this type of respiratory compensation, you can get good anatomical details of the vessel itself. Once you identify it, then you can select any region and you can produce vessel wall imaging. For example, now this is a right coronary artery in a healthy subject. We're positioning a slide to get the arterial wall here. You see the blood now is no signal or dark signal, and the arterial is here. And using high field Tesla may be helpful in looking at, because it gives you more signal, more details on the coronary artery wall as well. This is an example in an AD lesion in a patient, large eccentric plaque there, comparison with the angiogram as well. And now in the era of molecular biology, you can have nanoparticles, and on the surface of nanoparticles, you can put MRI contrast agent, and then either antithrombin, antifibrins, whatever the experiments, and then release them in the blood, and they will go and stick to the thrombus, for example, or fibrous tissue, and so on. And that's the electron microscopy before and after release of this agent in a pig model. You see high concentration of the contrast in the injured area. Same experiment, but in a rabbit now, targeting the fibrin part of the atheromatous lesion. We come now to the CT. Imaging of atherosclerosis can produce, give you information about coronary calcium scoring, CT angiography or limonography. And if you look at the source images of the CT images, you can look at the soft plaque as well. It's an example of extensive calcification in the LAD, proximal part of the right coronary arteries. This healthy volunteers without calcification there. It is, as mentioned this previous speaker, it is a marker of atherosclerosis process. It is rarely found in the absence of atherosclerosis. The amount of calcium increases with the amount of atherosclerosis, although not all plaques are calcified. It occurs in the intima, reflect advanced atheromatous lesion. Montgomery's medial sclerosis is exceedingly rare in the coronary arteries. And then from the calcium scores, if there is zero calcium score, then it is unlikely, it's highly unlikely to have coronary arteries. And then if it is a lot of calcification, more than 400 Hounsfield number, then it is high likelihood of at least one significant coronary artery stenosis. It is an unequivocal marker of atherosclerosis. Coronary artery calcium burden correlate with severity of atheroma. Coronary artery calcium scores related to individual cardiovascular risk and provide incremental prognostic risk assessment as well. This is an example of cumulative survival in men and women according to the score of calcium. And you see that this drop both in both sexes and drop on cumulative survival on both groups. This is an example here now of soft plaque there. You see it on the angiogram. There's very little calcification there, or no calcification, and you see quite nicely that lesion there. Spectrum of the disease itself from non-calcified lesions to different type of calcification, bulky, probably inflamed, healing, remodeled type of lesions, and so on. The type of calcification is different in acute coronary syndrome and stable angina. Most of the plaque are non-calcified in the acute coronary syndrome, while most of the plaque is calcified in the stable angina patient. And finally, if you look at the atherosclerosis, it has two components, the sclerotic part of it and the atherosis part of it. And the sclerosis is not very well kind of studied, and maybe it can be used for early detection or early understanding of the disease process. There's a lot of interest of looking at the aorta because of size, relative mobility, and good approach for MRI and CT scan. And the aorta is not a simple tube which transmits blood from A to B. It's far from it. It has a mechanical filtering function which converts the intermittent cardiac output to a steady state flow at capillary level. So if the aorta gets stiff, you stab the heart twice. First of all, it will act as a high resistance. Secondly, at 3 coil in diastole, it pushes the blood toward the coronary artery, and therefore you may also interfere with the coronary circulation. You can assess it, for example, by looking at the distensibility or change in the area during systole and diastole, and from that and the simultaneous measurement of blood pressure, you can work out the distensibility of the compliance of the vessel, which drop with age, and also drop in patients with coronary artery disease. And athletic subjects, healthy subjects, maintain their aortic compliance for even a higher age. So you can use this technique, or you can look at the propagation of flow waves in the arteria. Because when the ventricle ejects blood in the ventricles, it generates two types of waves, pressure waves and flow wave. And the speed of the wave depends on how elastic the artery, because the blood is incompressible. So if the artery is elastic, the flow wave is very slow, because the artery will distend. While if the artery is stiff, then the flow wave will be very fast. That can be used in a number of vascular beds. You can work at the distance from anatomical area, for example, from 1 to 2 in the aorta, and at the same time, you can work out the transient time for the flow wave to go from 1 to 2 by looking at the flow curve against time. And from distance and velocity and time, you can work out the velocity of the propagation. This is flow curves in the ascending aorta and in the thoracic aorta of healthy subjects and elderly subject. And you see that transient time is much longer in the healthy subject compared with the elderly subjects, young subject and elderly subjects. And that compared with pulse wave velocity, so age against pulse wave velocity now positively correlated, while if you correlate distensibility against pulse wave velocity has inverse relationship due to stiffness, as I alluded to earlier. Also, reactive hyperemia. If you put pressure on the arm, for example, or the leg sufficiently for sufficient time and they release it, what happens that the blood rush quickly, and therefore the high shear stress on the endothelium will lead to release of nitroxide, and that will produce dilatation of the vessel. 5 minutes after this procedure, you get dilatation of the, so that's what's called flow-mediated dilatation. It's commonly done by ultrasound, but it can be done with MRI, again, because you can put a surface coil very close to the brachial artery, and you can study, work out, not the diameter like ultrasound, you can work out the cross-sectional area with MRI and look at the changes. And at the same time, because the factor which inducing all this is the blood flow, you can measure the blood flow, instantaneous blood flow, real-time blood flow measurements before application of the cuff and after the release of the cuff until it releases to back to the baseline level. And that's make it very powerful type, very versatile tool, because you can introduce by the factor which produce the flow-mediated dilatation and the dilatation itself. So here you have the reactive hyperemia, the brachial arteries of normal cohort and patient coronary artery disease. You see there is a blunt response of the reactive hyperemia in the patient with the coronary artery disease, while it is respond to nitroglycerin. This is an MRI study now. They're looking at three things. They're looking at the cross-sectional area. They're looking at the velocity in the right coronary artery and the flow in the right coronary artery from velocity and the cross-sectional area during isometric exercise. And here you see the changes, percentage changes with isometric exercise in healthy volunteers and patient with coronary artery disease. And you can see the significant difference between the response of the healthy subjects and the patients. So in summary, MRI and CT are emerging as a promising contender for visual imaging, with the clinical results have been reported for coronaries, carotid, and the aorta. Currently, evaluation of atherosclerosis in the carotid arteries by MRI is superior to that of the coronary vasculature for the things I mentioned. MRI permits reliable, non-invasive serial in vivo plaque imaging, including composition without ionizing radiation. CT, on the other hand, is very fast, very quick, provide information about calcium and imaging of the soft plaque. And because of the speed, you can produce the images in seconds. It is much easier to apply for the coronary arteries. And finally, functional and hemodynamic information and molecular MRI are feasible, with many more developments in the pipeline. Thank you for your listening.
Thank you very much indeed, Professor Mohiaddin. Now, this very interesting paper is open for discussion. Can I ask you, in trying to increase the resolution, is 3 Tesla MRI more useful than 1.5, for example?
It depends where you're measuring, because getting more signal, if you're going to benefit from it, yes. The problem with 3 Tesla or high field in general, that you get higher signal, but you create other problems because you get a lot of artifacts. It's not easy. So it is not as simple as that. High field equate to high signal, equate to high resolution.
But the pictures you were showing us were quite good. These were done on 1.5.
Yeah. But those for carotid arteries.
Yeah, and the coronaries looked good too. I mean,
for the coronary arteries, yes, but it need a lot of skill. It's not a lot of training to do those type of studies.
The patient you showed us with carotid, and you showed the pathological specimen. How did he die?
He didn't die. It's endarterectomy.
Oh, this was an endarterectomy specimen.
Yes.
It looked like a whole artery.
He's alive and.
Oh, great!
Yes.
I'm delighted to hear that. Yeah. Yes, sir.
I want to ask you about the role of virtual histology for studying the lumen wall calcification. Is there any role for this, or it's out of? Yes, I mean in CT,
yes.
We do virtual histology in some of the machines with some software. Does this help in knowing the calcification degree and the nature of the lumen wall, or it doesn't help in this?
No, I think, as I said, soft plaque, non-calcified plaque is more vulnerable to rupture and events compared with the calcified plaque itself. If you're talking about how to use coronary calcium as a screening tool, and that's more contentious topic. The guidelines, as mentioned by, I think, Professor Folks, this previous
Your
session,
time is up.
It is maybe useful in some of the paper he showed in the patient with the intermediate risk. So it's not the low risk, not the high risk patient in the intermediate risk.
Professor Newby.
There was a lot of interest in USPIOs, ultra-small particles of iron oxide at one time. I just wondered whether interest in that has waned, or you just didn't have time to mention it.
I didn't have time to mention it because you have to compromise with talk like this wide topic. But from watching it, it's kind of leveled, or it hasn't been a progress that much. And I think the reason probably for the things you mentioned, that is different macrophages which lead to different things. There's a lot of work on experimental animals and showed that accumulation of the iron oxide by the macrophages. Whether these are the type of macrophage which will infect the damage or not, nobody knows. So it tapers, but there is some group still pursuing it.